Welcome, everybody, to our December iteration of our ongoing webinar series here at Nerva. My name is Joe. I'm the head of provider partnerships here in the US for Nerva and Mindset Health. And today I am joined by Morgan Binder, who is both a physician's assistant and registered dietitian, specializing in gastroenterology, practicing out of Arizona. Morgan has both a strong foundation in clinical nutrition and GI medicine, focusing on preventative, lifestyle-based care that takes an integrative and whole person approach to managing GI conditions. She's super passionate about helping patients understand how their systems are interconnected and empowering them with very practical and sustainable strategies to help improve their GI conditions. Today, she's going to be talking about IBS and IBD nutrition, using an evidence-informed care strategy for patients in the real world. So we're super excited about Morgan here to present. And yeah, with that, I will hand it over to Morgan.
Okay. Hello, everyone. Thank you for taking the time out of your day to be here. And then thank you, Joe, for the introduction and helping facilitate today's discussion. I'm excited to talk with you today about my experience providing nutrition care alongside medical management for patients with irritable bowel syndrome and inflammatory bowel disease. So we have a lot of info ahead of us to get into. So we're going to try to do our best to get through everything. Today, I'm going to be speaking about rethinking nutrition in IBS and IBD. We're going to be looking at evidence-informed care for our patients. Our objectives are listed here, so I'll go through these so we have an expectation of what we're going to cover. We're going to explore how nutrition's role in IBS and IBD care is shifting from restriction to regulation. We want to understand how integrating diet, psychology, gastroenterology can help improve our patients' outcomes. We're going to learn how to translate some clinical nutrition evidence-based practices, so looking at some specific research studies, and we're going to apply them to real-world strategies for our patients. And then we want to discover ways to support patients in rebuilding their confidence with food and reducing some of that symptom anxiety that can be seen with these conditions. And we're going to talk about how a multidisciplinary team can help collaborate effectively to deliver cohesive care for our patients. All right, so I'm sure we're all pretty familiar with IBS, but I do want to go over the definition. So clinically, IBS is going to be defined by the Rome 4 criteria, and that's going to be based on having abdominal pain related to defecation with an associated change in stool frequency or consistency. And then this has to occur for at least 1 day for a week and at least 3 months for at least 3 months in duration to make the diagnosis. And there are various subtypes there. Pathophysiologically, when we talk about IBS, we talk about this being a chronic disorder of the gut-brain interaction, and it's really best explained by looking and understanding the gut-brain axis. So we're going to get into this more in some of the following slides. Something I want to highlight here that I try to include when I talk to my patients about this being a new diagnosis is that IBS is relapsing and remitting. So it's not a forever diagnosis. If we do a good job managing the disruption between the gut-brain axis, many patients will have kind of mild to no symptoms the majority of the time, and that's really our goal. Okay, so let's talk about the gut-brain axis. I am by no means an expert on this, but it is crucial to this presentation to spend some time here because what I really want to emphasize is that IBS is not a condition of food intolerance or poor diet, and I think that's a misconception that a lot of our patients have. I see so many patients that come into the office and the first thing they say is, well, I want to fix my diet to manage my IBS, and I think they're kind of missing some of the key information there. So IBS, as I said, is a disorder of the gut-brain axis. Our brain and our gut are in constant communication, and it does this through nerves, hormones, immune signaling, all of which helps shape our digestion, our mood, our pain perception. So there's a lot going on there. And it's done through this complex bidirectional communication. So our central nervous system and our enteric nervous system, so the nervous system of our GI tract, work together, and they communicate directly by sending signals. They communicate via endocrine-based signals, so stress hormones and gut peptides, and then through immune-mediated pathways as well. So inflammation can send signals that tells our body what's happening. And then factor in our microbiome, and this can interact at all these different levels. So As we can see, there's a lot of complexity in how this diagnosis works. And then all of this ultimately is going to tell our body information about motility, secretion of gastric fluids, immune activity, pain, mood, etc. And then if we look at all of the factors that contribute, we see genetics, physiologic and psychological responses to stress, diet, age. There's so many factors here. My take-home point here is that we really want to understand that IBS is sensory amplification due to a gut-brain dysregulation. So it's not damage or inflammation, and that's something that's going to be more consistent with a diagnosis of inflammatory bowel disease. If we aren't taking the time to understand this and in turn really educate our patients on this, I feel like we're doing them a bit of a disservice, because I've seen that patients will continue to fixate on thinking that IBS is all due to food triggers, and they don't do a good job making progress in managing their condition because of that. We'll continue to hear the same old, I can eat this food one day and feel perfectly fine, but then when I go to eat it the next day, all of a sudden I have horrible diarrhea or, whatever their symptoms might be. And this leads me into talking about the IBS threshold. So I really try to spend time explaining this to my patients. We talk about Caesar threshold in medicine, and I feel like this concept applies really well to help explain IBS. I tell my patients that anyone can have days where they have abdominal pain, diarrhea, bloating, etc. But someone with IBS is going to have a much lower threshold for what's going to tip them over the edge or kind of overfill that bucket. So here I listed some of the main diet and lifestyle factors that I found to have a large impact on patients with IBS, and you can see them there: alcohol, caffeine, some specific dietary components, stress and anxiety, poor sleep, and then meal patterns can have a factor as well. When I counsel my patients on this, I try to give them examples that are applicable and make sense. So I'll tell them things like, okay, so let's say you have a day where you've only slept 5 hours and you're stressed about a work presentation. Then your stomach is kind of nervous. You don't really feel like eating. So you just grab a cup of coffee on an empty stomach and you skip breakfast. And then lunch is a little bit rushed. You just eat at your computer pretty quickly. And then by the end of the day, you got to dinner with your coworkers. You want to celebrate finishing that stressful work day. And you maybe overindulge in some fatty or greasier food. You might have a drink or two. Well, I won't be surprised if this is going to flare up some of those IBS symptoms, because we've put in a lot of different factors into that bucket that might tip us over the edge. But say instead you're working on raising your IBS threshold. So it's the same scenario. You still didn't get good sleep and you're stressed, but instead you start the morning with a good breakfast and you skip that cup of coffee. And then you take that 15 minutes to do meditation on the Nerva app. Lunch, same thing. You're eating the same food, but instead you take 15 minutes out of your day and you just sit there and you eat lunch uninterrupted. And then another 10 minutes to just go for a walk afterwards. Dinner, same scenario. You go out, you have a couple drinks, you eat what you eat. We've now taken the time to raise our IBS threshold with those small changes throughout the day. So those triggers often don't have as big of an impact. When we look at raising the IBS threshold, we're looking at trying to fix some of that interaction between the gut and the brain axis. And if we do a good job at this, the goal is that we can have patients start to liberalize their diet more and not have so much fear and anxiety around eating these foods. Because at the end of the day, food is celebratory, it's cultural, it brings joy. We don't want patients to feel like they have to stick with a really strict diet. And when I go through this, I try my best to counsel patients on, the importance of getting sleep, stress management, fiber tolerance training, all these things that factor into helping raise that threshold. But this is really something that, not all of this is within my expertise. So I do rely on referring out and having an interdisciplinary team to help with the rest of this. The key takeaway here is really that IBS is not just about what information we give the gut, it's about how it processes it as well. So I'm going to go through some specific dietary and nutrition strategies for managing IBS. The first here is just looking at the traditional IBS dietary advice. And this is where I start with my diet and lifestyle counseling for patients. And often this is really as much as I have to do. So these guidelines are available and up to date. I did add these notes here in green, which were just some kind of like anecdotal points I wanted to add that I found to be helpful for patients. So we'll just go through some of this here. With IBS, we really want to be mindful of meal planning. So eating more regular meal times, avoiding skipping meals. For some patients, they might do better if you're kind of having smaller meals. Really something I stress with my patients is eat when you are relaxed. Our body wants to be in a parasympathetic nervous system, rest and digest. So take that time out of your day to eat in a more relaxing environment and then chew well. That's really important. I have so many patients that'll say things like, well, my stool shows undigested food. And I remind them that your first form of digestion begins with chewing. So that's a big point here. And then looking at some specific foods that might be important to limit or avoid, there's a list of gas-producing foods that I'll go over quickly. And then high-fat or greasy foods, lactose-containing foods. And that's not because there's necessarily a higher incidence of lactose intolerance with IBS. It's more that patients who have IBS and lactose intolerance are probably going to be a bit more symptomatic. And then we want to look at other types of insoluble fibers that might cause some GI distress and identifying any personal IBS triggers along the way. Then looking at some foods and supplements that would be helpful. We know that soluble fiber can really benefit our IBS patients. So psyllium husk fiber is a big one. I tell patients to start with a smaller serving, so 3 to 5 grams. I like them to take it in the evening times. If they need a specific, I say, sure, 45 minutes to an hour before bed. And then there's some other forms here listed. I do tell patients, maybe caution with a bunch of legumes initially because those can cause more gas and bloating. So that might be something we add in as symptoms are starting to improve. And then it's important to stay well hydrated. And I really stress with patients, avoiding a lot of intake of alcohol, caffeine, and carbonated beverages as well. So here's a list of foods that are commonly associated with gas and bloating. And I'm not going to really go through all these here. It's more just for reference. But I did want to add an additional note that I put here at the bottom. So caution patients with the sugar alcohols. So these are ingredients that are going to end in OL, like erythritol, sorbitol, xylitol. And that's because for a lot of people, this can cause more gas, bloating, and diarrhea. And some patients don't realize that if they're consuming a lot of diet products or sugar-free products, they might be getting in a pretty high intake of these, and that could be a factor in their GI distress. Okay, so now let's talk about psyllium husk fiber. This is really the one supplement that I feel passionate about, that I can say I've truly seen a significant improvement in my IBS patients when they're taking this. So I added a couple brands here that I've tried and can vouch for in terms of taste and ingredients. So there's a lot of better options than just Metamucil, and that's what I try to tell my patients. I will note sun fiber that I listed here. It's not psyllium husk fiber. It's made from the guar plant. And it's a good option for those that don't really tolerate psyllium husk fiber as well, maybe because of the gas or bloating. A major tip I wanted to add here. So anytime I'm working with patients to increase fiber in their diet, if they're more of a constipation predominant or they're just having kind of incomplete evacuation of their bowels, I'll have them do a bit of a clean out with Miralax first, and then they can start on the fiber supplement. And that's because I've really found that for the vast majority of patients who get those side effects and say that they didn't really tolerate psyllium husk or that it didn't work well for them, it's usually because they have a lot of stool backed up in their colon. And then as a result, when they're consuming all this fiber, it's not really pushing things through. It's just kind of sitting there. And then the bacteria breaking that down and just causing more gas and bloating. So if it's more of a mild constipation, I put some guidelines here, but I usually tell patients start with a couple doses of Miralax in the evening, and they can do this for a few days in a row until they've had a couple better bowel movements. If they're really constipated, this might require a bigger clean out with more Miralax or even using Go Lightly. Then after this is when I have them start taking the fiber supplement. And I like them to take it in the evenings just because if there is a little bit of fullness or bloating, they're going to go to bed and those symptoms don't become as bothersome in that case. Okay, so the low FODMAP diet, we see this a lot in IBS, and I think this is a really common one out there that patients will ask about. So I reserve this diet for patients who do not get adequate relief with the traditional dietary advice that we went over, or there's some who are just really eager to try it. So low FODMAP diet is low in fermentable, oligo, diet, and monosaccharides and polyols, which are certain types of short-chain carbohydrates, and they're poorly absorbed in the small intestine. So instead, they stay osmotically active. They're going to pull in more water, and that's going to cause more rapid fermentation. It's going to cause some luminal distension. There might be a little bit of intestinal permeability, and then this in turn leads to symptoms like the bloating and the pain that patients experience. There have been numerous studies that show improvement in global symptom scores with patients following a low FODMAP diet compared to placebo. We do see that this might have a bit of a higher efficacy with our IBS diarrhea subtype patients versus a constipation subtype. And then this is really not a long-term solution. So I don't keep patients on this diet forever. I find that it can be really helpful if symptoms are flared, and it provides a bit of like rest and relief from symptoms so that we can focus on improving the gut-brain axis with those other strategies. And then when we go to reintroduce foods, it's kind of like the nervous system has almost calmed down enough that that threshold is higher. And then when we do reintroduce foods, we can ideally identify if there are any specific dietary triggers. So here's just a reference slide of a list of high FODMAP foods. I always try to start with giving a list of low FODMAP foods so patients know what they can eat versus what they can't eat. Okay, so this is just kind of going through the basics of what the low FODMAP diet entails. So in step 1, we're going to eliminate high FODMAP foods, so that list that I just showed, and that's going to take usually between 4 and 6 weeks. If symptoms are improved, then we're going to move on to the reintroduction phase, which is step 2. If there's no improvement, there's no need to do the reintroduction phase. So step 2, it would be that gradual reintroduction phase. So we're adding back in our high FODMAP foods, and that takes a while because we're typically adding in just one high FODMAP food at a time and then giving it a couple days in between to see if there are any symptoms. There's also the option to try a modified low FODMAP diet. So that just cuts out fructans and galacto-oligosaccharides. This hasn't really been validated, but it might be a more approachable option for patients. And then this is a scenario that would be really great to work with a dietitian. I know that that's not feasible for a lot of patients. So a resource that I rely on a lot is the Monash University Low FODMAP app. And patients can use that to help guide them through this diet. And they also have cookbooks available and a lot of resources on their website. Okay, so supplements and IBS. This is a big one that patients ask about. So there are a lot of supplements out there. There's a lot of marketing to patients with IBS saying, hey, if they take this one thing, it's going to fix all their symptoms. I've done some research, and then just anecdotally from what I found, the one that I see a bit higher efficacy is with enteric-coated peppermint oil. So there's some data to suggest that this can help with decreasing IBS symptoms. We're going to go through a little bit of this trial here. I do want to note this specific trial was funded by the manufacturer, so keep that in mind. So with this trial, that it's called IBS Rest, it evaluated the efficacy of enteric-coated peppermint oil versus placebo in patients with IBS, and the goal was to look for a reduction in symptoms. The mechanism of action is mainly due to the L-menthol, which is one of the active ingredients in the peppermint oil, and it can help relax the smooth muscles, and that's the type of muscle that lines our bowels. So this can be beneficial for like cramping, distension, bloating type symptoms. There are some additional benefits listed here as well that can be from that peppermint oil. So for this study, it was a 4-week randomized double-blind placebo-controlled trial, and like I said, it was assessing the peppermint oil versus placebo. There were 72 patients, and then it was a mixed group. So some had IBS mixed and some had an IBS diarrhea predominant subtype. The treatment was to give the peppermint oil 180 milligrams 3 times a day for 4 weeks. And then looking at the endpoint, so the primary endpoint was to see a change from baseline in the total IBS symptom score. And this is really just based on 8 different type of IBS symptoms. So here is a graph to help illustrate the results. I'm going to try to orient us here. So on the y-axis, we see the total symptom score. And then on the x-axis, it breaks it up into the two different groups. And then it's looking at baseline, 24 hours, and 28 days or 4 weeks into the study. On the left, the dark gray is a placebo group. And then on the right, that shaded gray is the peppermint oil group. So for the peppermint oil group, we see that at 4 weeks, there was a statistically significant decrease in the total IBS symptom score. So our primary endpoint was met. Which essentially says the peppermint oil capsules helped. They helped decrease our IBS symptoms. And they actually saw that this happened as early as 24 hours after starting those capsules. With the study, they saw that the most common adverse events reported in both groups was flatulence, dyspepsia, and GERD. There was a little bit actually higher incident in the placebo group, and we could say, maybe that's because the medication was helping reduce some of those other symptoms in the other group, but that's just speculation. So for the trial, they used IBGuard. This is something that we can find in a CVS or Walgreens. It is pretty expensive. So what I found is another good option for patients. It's this Protocol for Life brand. We don't have any specific studies that I can reference here. Dosing is different, so just keep this in mind. They would only need one of these soft gels versus the 2 capsules for the IBGuard. Okay, so we're going to shift gears here and now talk about nutrition and inflammatory bowel disease. So I want to do a bit of an overview on defining IBD. So IBD is a chronic immune-mediated disease of the GI tract, and it's characterized by inflammation, ulceration, tissue damage, and then it's also this relapsing and remitting course as well. There are 2 main subtypes. There's ulcerative colitis and Crohn's disease. So ulcerative colitis only affects the colon. It's going to be limited to that innermost lining, so that mucosal layer. And it usually involves the rectum and then can extend in a more proximal, continuous fashion. With Crohn's disease, this can affect anywhere from the mouth to the anus, although we primarily are going to see small bowel and colonic involvement. And then this can affect all 4 layers of the GI tract. Crohn's disease characteristically is going to have these skip areas. So we might see segments of normal appearing bowel and then segments of diseased bowel. And then because of that transmural involvement, we can see over time that patients might develop fibrosis, strictures, fistulas. So these are kind of complications of having Crohn's disease. Crohn's disease, also here, etiology is not really well known. Our understanding is that it involves an interaction between genetics, environment, microbial factors, and then our immune response as well. IBD can largely affect nutritional outcomes. So working with these patients, you'll see that there are certain symptoms or disease phenotypes where maybe patients who are struggling with a lot of symptoms like abdominal pain and diarrhea, or they just have higher disease activity, or maybe it's the location of their disease that can start to affect their nutritional status. So they might be avoiding eating, or they might be kind of having these restrictive eating patterns, or they may even have some maldigestion or malabsorption. Or in some cases with a really high disease burden, we can actually see that they start to have increased energy needs, and then they can have GI protein loss through their stool as well. So over time, if this continues, we can start to see some poor nutritional outcomes where patients might have macronutrient or micronutrient deficiencies. We start to see changes in their body composition where they might be losing weight and muscle mass. And then bone disease, so osteopenia and osteoporosis are a risk as well. As we just talked about on the last slide, macronutrient deficiencies can lead to the malnutrition over time. So it's helpful to monitor weight at every visit when we're able to. It's not the definitive factor in understanding nutritional status, but it can give us a little bit of information here. And then it's also important to note that some patients might have some increased energy needs during an acute flare. So with protein, we can see that those needs actually increase a bit during acute inflammation, and they might be as high as 1.2 to 1.5 grams per kilogram versus just the 1 gram when our symptoms are more or when patients' symptoms are more in remission. And then with micronutrient deficiencies, this can be really common in our IBD patients as well. So we know that disease activity and location, as well as certain medications, can start to interfere with micronutrient absorption and some of the metabolism there. So it's important to do regular monitoring with these labs that I listed out here. So we want to be checking our CBC and assessing iron stores. For patients that maybe are having a lot of diarrhea, it's important to monitor their electrolytes, their kidney function. Vitamin D is really important, especially in patients that are on a lot of steroids. B12, folate, we can see with sulfasalazine and methotrexate that this can start to inhibit some of the folate absorption. And then our fat-soluble vitamins are really important, especially in patients that have more disease affecting the terminal ileum, so those patients with Crohn's disease, or maybe they've had an ileal resection, so they're losing that surface area that we really have our fat-soluble vitamin absorption take place. And then zinc, this is one that we might see more if patients are having a lot of output, whether that's diarrhea or ostomy output. And then really important too is to be checking a DEXA scan on your IBD patients, especially if they're underweight or if they have excessive steroid use. So if they're on steroids more than 3 months out of a year, then really think about checking a DEXA. And then we're always checking our CRP and our fecal calprotectin. This is just a good way to monitor for signs of inflammation. Okay, so now we're going to talk more specifically about the diets available for our patients with IBD. I'm going to go through these different diets and discuss what scenarios they might be most applicable. So we'll talk about the Mediterranean diet, the low FODMAP diet. There's some specialized oral diets here, like the specific carbohydrate diet, the modified specific carbohydrate diet, Crohn's disease exclusion diet, and then enteral and parenteral nutrition. And then we'll talk a little bit about some modified texture diets as well. So this slide is an overview of some more basic nutrition recommendations for our IBD patients. And this is for some people like as much as I introduced initially. So the International Organization for the Study of IBD put together these evidence-based recommendations of potentially beneficial and potentially harmful dietary components. The take-home points of their consensus are listed here. So patients with Crohn's disease may benefit from increasing fruits and veggies to get more dietary fiber, whereas patients with ulcerative colitis, we might see more of a benefit with increasing our natural sources of omega-3 fatty acids. Really something else I wanted to highlight here too is the list of potentially harmful ingredients really just focuses on avoiding processed foods, and it specifies that, certain ingredients that might be more harmful there. There wasn't enough evidence to make recommendations on some specific foods like gluten, poultry, alcohol, so we don't have a lot of information to advise patients on that. Additionally, they noted that in patients who do not have any active inflammation but are still having persistence of symptoms, that this would be an appropriate time to trial a low FODMAP diet or a lactose-free diet. Okay, so what diets can we use and when would they be appropriate? So we're going to look first at the Mediterranean diet, and this is really what I recommend for all of my IBD patients, and we'll get into that on the following slides. So this can be a helpful diet for IBD patients when when their disease is in remission and they are not having symptoms, or even if their disease is in remission but they're having IBS type symptoms. And then we'll even talk about scenarios where it might be helpful for patients who are having an active IBD flare. So the AGA put together recent best practice guidelines based on review of existing literature and then looking at expert opinion to make these recommendations. So unless there's a contraindication, we really recommend for all patients with IBD that they should be advised to follow Mediterranean diet. So this diet, in a nutshell, it's rich in soluble fiber in the form of fruits, veggies, and whole grains. So we can see that at the bottom of the pyramid there. And then there is an emphasis on lean meats and seafoods, getting high amounts of omega-3 fatty acids. And then as we move up on that pyramid, we're having smaller amounts of processed foods, red meats, and dairy. So previously, our IBD recommendations really focused on fiber restriction. But now we're finding that there's actually an emphasis on increasing fruits and veggies so that we can get higher amounts of soluble fiber. And this is really because we're starting to understand that soluble fiber can help with the production of short-chain fatty acids. So our gut bacteria can help with producing these, and then they have some anti-inflammatory properties. There was a recent study that showed that in adults with mild to moderate Crohn's disease, that looking at a Mediterranean diet versus a more restrictive diet, like a specific carbohydrate diet, actually had really similar efficacy in achieving symptomatic remission. And there were some response in biomarkers as well. And we'll talk about that more in later slides. And then also, the Mediterranean diet is helpful for patients with various comorbidities. So this is an easy one if we're not really sure what might be appropriate in other scenarios. Another option for our IBD patients in remission but still experiencing those IBS symptoms would be to try the low FODMAP diet. So we already talked about this with IBS, and there's really not a lot of different information on it here. We do have some research that shows efficacy of a low FODMAP diet to decrease IBS symptoms, improve quality of life, but we don't have any data that supports that we're going to see an improvement in inflammation or biomarker response. So same with IBS, we do not recommend that we're on this diet, that patients are on this diet long term. And that's because we think that there can be some change in microbial composition over time where our beneficial bacteria start to decrease. And then there can be a decrease in short-chain fatty acids like butyrate, which is really helpful for the gut lining. So sticking with the same recommendations here for our IBS, we do the elimination and then the reintroduction phase. Okay, so now let's transition to talking about our IBD patients in an active flare. So we mentioned the Mediterranean diet can be an option. And then there's some additional diets like these specialized oral diets and enteral and parenteral nutrition, which we'll talk about. So the specific carbohydrate diet, the hallmark of this diet is to promote simple carbs instead of complex carbs. So it's a little bit counterintuitive to what we traditionally think. And this is because simple carbs are more readily absorbed and they essentially will require less digestion. And if we have more undigested complex carbs, this can be a substrate for pro-inflammatory bacteria, which can cause more symptoms like gas, bloating, inflammation as they start to break that down. The diet is really best explained by foods to emphasize and foods to avoid. So there's an emphasis on consuming unprocessed meats, minimal lactose. So all of this is in that box in green. Most nuts and seeds are okay, some legumes and some fruits and veggies. So we're kind of minimizing some of those sources of fiber here. In contrast, you want to avoid all grains, nearly all sweeteners, a lot of dairy, starchy vegetables, some legumes. And then really they emphasize here too, avoiding things like artificial sweeteners, additives, processed foods. So we're seeing a repeat or an overlap of this type of information again. Okay, so now I'm going to talk specifically about this study that looked at the specific carbohydrate diet, which we just talked about, versus the Mediterranean diet, which was a few slides back, and looking at how this can be appropriate for our patients with active IBD. So the goal of the study was to compare the efficacy of these two diets as a treatment for Crohn's in patients with mild to moderate symptoms. So it looked at adults with active Crohn's, like I said, mild to moderate symptoms. And this was based on the specific shortened Crohn's disease activity index. And we're not going to get into all of that. But basically, this was a randomized 1-to-1. So patients either were on the specific carbohydrate diet or the Mediterranean diet for a total of 12 weeks. In that first 6 weeks, they were given food. And then in the second 6 weeks, they had to supply their own food. They were also stable on some medications. And then they looked at the primary outcome, which was symptomatic remission at week 6. And our secondary outcomes, we're looking for improvement in our biomarkers, so fecal calprotectin and CRP. This slide shows the results. So the data shown here is for week 6, since this was the primary endpoint. At the end of the study, there were 191 patients that were included in the efficacy analysis. And the primary outcome was met. So if we look at the first set of graphs here, this shows that about 50% of participants achieved symptomatic remission. And of note, there was no significant difference between the two diets. So the efficacy was the same here. The second and third set of bar graphs shows our secondary outcomes. So we see that 30 to 35% of patients had a response in calprotectin, although there was no difference between the two diets, but the specific carbohydrate diet did have a clinically significant improvement in calprotectin when we looked at the comparison from baseline. And then looking at the final set of bar graphs, this was looking at CRP response, which was minimal, but the CRP values were not really elevated in this group to begin with. And then the 12-week outcomes were similar. So really the take home here that I'm trying to illustrate is that both of these diets have really similar efficacy for helping with symptomatic remission. And then there's even some potential for biomarker improvement. But the Mediterranean diet might be more appropriate just because it's less restrictive. Okay, and then there is also a modified version of the specific carbohydrate diet. And really what this is doing is just liberalizing the diet some by adding in an additional 5 foods. So there was a randomized control trial looked at this specific carbohydrate diet versus the modified versus a whole foods diet. And this was just done in a small group of PEDS patients who had mild to moderate Crohn's over 12 weeks. So a very small subset, only 10 completed the study, all achieved clinical remission and improvement in their CRP. They did see that the more exclusionary diets had a greater decrease in CRP. So really, the take home here too, why I'm showing this is not because this is like a really robust or impressive study in terms of numbers, but it helps illustrate that we're seeing that these diets really can have a benefit for our IBD patients. Another option for patients with IBD that are in an active flare would be to do a Crohn's disease exclusion diet. So this diet combines a whole foods diet with partial enteral nutrition. So the goal here is to limit foods that are believed to negatively impact intestinal microbiome, barrier function, or induce colonic inflammation. There's some emphasis here on like high quality proteins, resistant starches, kind of a moderate amount of fiber, and then avoiding certain types of foods, which they do include additives and emulsifiers here as well. So this diet consists of 3 6-week-long phases. Basically, phase 1 and 2 is to induce remission. So in phase 1, patients are having 50% of calories from oral supplements, and then the remaining 50% is from a pretty restrictive diet. Phase 2, they decrease the amount of oral supplements to just 25% of calories and start to begin to liberalize that diet. And then phase 3 is the maintenance phase where they're still consuming some calories from the supplements, but they're really starting to liberalize the diet more. So some clinical trials have shown remission rates similar to that of exclusive enteral nutrition. So this would be a more practical approach with similar results. And typically this response takes about 6 to 12 weeks. So these studies were done, initially using a specific formula called Modulin IBD, which is produced by Nestle. But they found that other options may be appropriate as well. All right, and the final option for our IBD patients who are in an active flare that I'm going to talk about is exclusive enteral nutrition. So this is getting 100% of calories consumed as enteral supplements. So we're drinking shakes or, for a patient that might be in a more severe scenario, they would be on a tube feed. So looking at the summary of data on this, we can see that it can help promote mucosal healing. Typically, this is going to be done over 6 to 8 weeks. And it's actually an option for first-line treatment prior to using steroids for pediatric patients with Crohn's. We have a study that shows similar clinical remission rates to steroids with 60 to 80% remission after 6 to 12 weeks. This is a lot harder to do in adults, and that's why a lot of the research on these diets is typically in a pediatric population because adherence is harder with adults because we make our own food and we have more choices. The goal here is to induce remission, and then you start to liberalize your diet. And then reading through these slides had me kind of thinking, would it be an option to just make your own smoothies versus having to drink these shakes? The reason I bring that up is because if we look at the ingredient list for the formulas that are often used, these don't really align with the guidelines of avoiding unprocessed foods. But despite this, we see really good efficacy. So the question here is it really the specific ingredients in these formulas and shakes that's providing the benefit? Or is it more just this bowel rest where we're minimizing the work our digestive system has to do? So it might be an option, or I would say it's a reasonable option, to have patients just make their own shakes at home. It's often cheaper and you have control of better quality ingredients. But convenience is a factor. So if patients aren't able to do that, there are some better quality popular brands out there like Kate Farms, Fairlife, Orgain. Okay, and then our final remaining scenarios to discuss are these specific situations like strictures, ostomies, where we might have to be using modified textures or even exclusive enteral or parenteral nutrition. For patients with symptomatic strictures, there was really an emphasis on avoiding fiber in the past, so minimal consumption of fruits and veggies. But now we're finding that it's okay to eat these. We just want to modify the texture. So that's chewing well, cooking really well, and even in some cases, pureeing the foods. If their strictures are more severe, then patients might need to use enteral or parenteral nutrition. So I'm going to reference some studies here as well. So there was a small study that showed in patients receiving exclusive enteral nutrition that they were able to achieve symptomatic remission, clinical remission, and even radiologic remission in strictures after 12 weeks. Another study showed that patients on exclusive enteral nutrition prior to surgery, so a fourth of these patients were actually able to avoid the need for surgery altogether. And then those that did end up having surgery had better post-op recovery. And that's probably because of the optimization in nutrition. Not going into the surgery malnourished is a big factor. And then lastly, we do see for patients with more severe complications like high output ostomies, fistulas, abscesses, that temporary parenteral nutrition may be beneficial. And I'm not going to go really into the detail because these are a bit more niche cases. All right. And then lastly, let's just talk a little bit about some supplements in IBD. This is also a hot topic that I'll have patients ask about. And, I really haven't seen anecdotally a lot of benefit to most supplements that patients have been on, but here are a few that have some research to kind of back them up. So VizBiome is a probiotic brand, and they do have some data to support the use of their product in patients specifically with ulcerative colitis for ileal pouch management. So if this is something where you have a patient in this situation, you could read more about that. And then another supplement I mentioned to patients who are asking is the supplement that's manufactured by Evanature. So it's a combination of curcumin and king dye, and it can be used to treat ulcerative colitis. So they have I'm not going to go into the details of the study, but if you're curious, there was a study that was published in 2024 in the Journal of Clinical Gastroenterology and Hepatology. And the study looked at efficacy of supplementation with the specific curcumin king dye supplement here in patients with active UC. And they had some pretty impressive results. So there was response in inducing remission in active UC patients after 12 weeks of supplementation. Okay, and that's all the information here. So I'm just going to go through and summarize what we talked about to just reiterate some of the important points here. So with nutrition and IBS, we really want to focus on understanding the gut-brain axis and help our patients understand this as well. We want to educate on the IBS threshold and talk about the importance of lifestyle triggers and how this oftentimes might have more weight than our specific dietary triggers. And then let patients know that we can raise the IBS threshold by managing some of those lifestyle factors better. And looking at traditional IBS dietary advice, this is often enough to help with our patients managing their symptoms. Emphasizing again, soluble fiber supplements are a wonder drug, in my opinion. And then we know the low FODMAP diet can be helpful for symptom reduction, gives us a little bit of rest to help identify potential triggers as well. And ideally, this is not meant as a long-term diet. And then lastly, with supplementation here, that enteric-coated peppermint oil capsules might have some benefit for reducing IBS symptoms. And then talking about nutrition and IBD to summarize here. So IBD patients are at risk for malnutrition, micronutrient deficiencies, and there are many available diets for them. So the Mediterranean diet is the least restrictive and usually is appropriate in most scenarios here. If we want to offer more restrictive diets, they do have a potential for improvement in biomarker response. So that's another option here. And then the low FODMAP diet as well. So patients who have IBD that's in remission, but still experiencing IBS symptoms could benefit from this. And then we have data that shows that these diets have the potential, like I said, for improving some of those biomarkers. And then in even some scenarios, they do show some improvement in endoscopic remission as well. And then same thing here, many supplements available for patients with GI issues. I'm a big fan of review the data. Sometimes less is more. Patients have a lot of things to spend money on. And if I don't see a big benefit, or if I don't have a lot of data to support a big benefit, I usually don't push these supplements on for patients. All right. So we're going to stop here, open it up for questions. I wanted to thank everyone for participating today and taking the time to listen.
Awesome. Thank you so much, Morgan. It was an awesome presentation, super informative. We do have a bunch of questions that have come into the Q&A. If you have any additional questions, do pop them into either the chat or the Q&A, and we'll get to as many as we can as part of the next 15 minutes. There is also now a link at the bottom of your screen to provide feedback on today's webinar. If you do have a chance before you sign off, please click that link and fill out the brief survey. It takes about a minute, but it really helps us improve webinars for future participants. So with that said, let's jump in. We must have a lot of IBS practitioners in the group. A lot of these questions focus on the IBS portion of the conversation. So Morgan, question for you. Is there a reason you don't start with sun fiber for better tolerance and work up to psyllium husk later?
Honestly, because I feel like most patients do a good job tolerating psyllium husk. It's just a matter of having them do a bit of a clean out with some laxatives first. So that's my reason, I guess, is I just haven't seen a lot of poor tolerance. So it's not my go-to.
Great. Another question here. Is it realistic to tell somebody to limit insoluble fiber from all non-starchy fruits and veggies? Do you start by recommending foods high in insoluble fiber that are also high in FODMAP? This could be quite a bit of restriction of healthy foods. Curious about your general approach.
Yeah, and that's I'm assuming this is specific for IBS, but that's why I don't really push a lot of these restrictive diets on patients. I like to talk about it and show for patients who are really curious that there are options and that they can have some pretty impressive benefits. But I think the feasibility of doing this, if we look at like, what is that giving patients more stress potentially? And is it really realistic? And yes, I mean, to your point, sometimes balancing like how are we getting enough fiber by avoiding these certain subtypes of specific foods or specific types of fibers can be really difficult for patients. And I don't have the time, right? Like I'm a practicing PA, I'm not a practicing dietitian. So I do as much as I can in a visit, but I don't really have the luxury of really teaching patients like each subtype of fiber and what foods that would be.
Yeah, great. Another question we have here is many patients I've worked with who do the low FODMAP diet have a significant difficulty reintroducing foods, which you talked about during your presentation. Can you talk about the evidence for long-term efficacy of reducing symptoms with the low FODMAP diet? Questioning if it's worth recommending low FODMAP at all, or if focusing on reducing symptoms with OTC supplements like Gas-X, Miralax, fiber, etc., would be preferred to a low FODMAP diet.
Yeah, I mean, I don't know if we have any specific studies. I don't have any specific ones to talk about like long-term efficacy, if that's more of the question. So yes, I mean, that can be the hard part as patients get stuck in this, like just being on the low FODMAP diet and having a hard time reintroducing. I truthfully find that to be these patients that are a little bit more of the like hypervigilance about reintroducing food. And I in that scenario spend a lot more time educating and working on like how do we improve our IBS threshold. And these are patients that might really do a better job having regular management with a counselor and addressing like what else is going on here that's causing us to fixate so much on these foods. Because I find that when patients are like their life is in good harmony and balance, that the like fixating on fear foods is a lot less. So to me, it's almost more of, I don't want to say it's like a psychological issue, but I think if patients start to let go of the fear, that the symptoms aren't as predominant.
Great. I think you covered this after the question was asked, but I'll ask it again. Can you share why you recommend fiber supplementation in the evening?
There is no specific data on this. This is all anecdotal. So I just have found that a lot of patients, bowel habits are often like a lot of people have their bowel movement in the morning, especially because people drink coffee in the morning and that stimulates the gastrocolic reflex. So the goal is that you take that fiber, and by the time you go to have a bowel movement, it's made its way to the colon where we're having the efficacy from it, right? We want it to firm up our stools. We want it to add bulk. So I just find timing wise, it makes more sense to having a result in that bowel movement. And then I also find that if there are symptoms like bloating or some fullness, that they go to bed and those symptoms don't really exist.
Yep, that's great. Do you have any thoughts on the Iberogast supplement? That's another one that seems to pop up frequently. It was asked by somebody.
Yeah, I don't have a lot of information on that one. I've seen it. I know I saw something that was like caution with people who are taking this regularly and liver disease, and it's some specific herb that's in there that has some potential for like hepatotoxicity. That's as much as I have to say about it. I mean, I don't think it's harmful to try. And some people just like to have something to do that makes them feel like they're addressing their symptoms.
So shifting a little bit away from the topic of diet and fiber, somebody asked a question about how do you determine, so as a PA, you have the ability to both prescribe medication, do diet counseling, recommend behavioral therapy for IBS patients. How do you determine what to start with?
Um, that's a good question. I don't know if I really have like a flow chart in my head. I really start with talking about the IBS threshold. Um, and I do my best to do like a quick kind of understanding of like what's their diet and lifestyle habits like. So I'll have patients just run me through like what does breakfast, lunch, and dinner typically look like? What are you drinking throughout the day? And with doing this over enough time, there's little things that I've found that I can kind of pick up on. So like patients who are like, oh, well, I start the day with, coffee first thing in the morning on an empty stomach and I have 2 cups. I ask them, are you having loose stools afterwards? Is that typically when you start to feel like these IBS symptoms flare? And if the answer is yes, then I say, okay, well, let's just start with cutting out caffeine or having a big meal prior to drinking that coffee so that it maybe doesn't have as tremendous as an effect. So, I don't know. There's not like a specific formula I use, but I would say overall just addressing more of the threshold, because I find that if I do a good job at that, I don't have to have patients be on these restrictive diets.
Yeah. Do you ever recommend patients try multiple things at the same time, like diet modification and gut-directed hypnotherapy for IBS, for example, or diet and a supplement?
Yeah, I do. In a perfect scenario, we say try one thing at a time so that we can see like the efficacy of each change. But there are so many factors that go into IBS, and if I were to do it that way, it would be maybe 6 months to get patients to the point where they're getting better symptom relief. So when it comes more to like a medication, or there's something that I'm really concerned is like a trigger might be a really important alleviating factor, then I think it's a bit more crucial to say like, hey, let's just try this one at a time. But otherwise, I often just have them make multiple changes at once in light of like wanting to improve their symptoms quicker.
Yeah, that makes sense. You kind of cued into this a little bit earlier when you were talking about how you talk about diet with your patients. But how do you approach educating your patients on diet modification or any other of these treatment strategies when a referral to a dietitian or a referral to a GI psychologist is not available. You're a PA, you only have limited time with the patient. These diets are often complex, or these protocols are complex. How do you handle bringing your patient up to speed or empowering your patient to succeed with those treatments?
I mean, part of it is like I do have a bit of a leg up in that I know diet stuff. I know how to quickly ask the right question. So I'm probably not like the best person to give up, the most standard recommendation here. But a lot of it is listening. So I really focus on using like motivational interviewing techniques. So I have patients, I listen and then I reiterate what I'm hearing. And like, as I said, I try to do like a quick dietary recall and I pick out one thing and I set a really realistic and reasonable goal. So if it's a patient who's drinking, 4 diet sodas a day, I just ask them like, what's a realistic number for you? If it's not 0, is it 3? Is it 1? And I just do like easy goal setting because really with like nutrition, everyone can look up how to eat healthy. It's the behavioral component that keeps people from eating healthy, right? It's making the changes in a way that builds confidence. So I do my best to really like reaffirm with patients that they're doing a good job and that 1 less soda a day is like, a huge feat on their end. And it is, right? Like changes are really hard and people have to start with something to build confidence. And then the other part too is I bring people back for regular follow-ups. Like if I don't have enough time to address it in that visit, I'd bring them back and we might do a more nutrition focused visit where we have time to get into that more.
So this question goes back to the very beginning of the presentation. But how you talked about your bucket analogy for patients, and I think that's a really good way of framing it. How do you, if it's that approach, then let me know. But how do you explain the gut brain connection to your IBS patients in a way that they actually understand? And like, how do you handle the pushback from them if they are skeptical about that being a driver of their symptoms?
I've kind of found like simpler phrases that I use. I mean, by no means do I go into the detail that I did for this presentation with patients, but I let them know like one of the phrases I often use is like old adages like butterflies in your stomach like exist for a reason, and we're really starting to understand that there's a big connection between our gut and our brain, and it's not that this is a psychological disease, that it's in your head and you're making it up. It's just some people have a lot more visceral hypersensitivity where the symptoms are a lot more impactful in their body. And I'm trying to think like what other kind of simple ways I have to explain it. I don't really get a lot of pushback from patients. I find that there are definitely like we might see these like subtypes of patients that are a lot more anxiety driven patients that you can tell that maybe they struggle with OCD or other types of disorders where there's a lot of kind of fixating, and it's finding the right balance. And sometimes I have patients that I can address that more like head on and say like, hey, it seems like a lot of the issue here is kind of fixating. Would you agree? And it takes, it's kind of an art form to understand how to bring that up. And it's not every patient that I can say things directly to. But a lot of the time I'll have patients say like, thanks, that really helped me understand this a lot better. And like, I feel like no one has explained it in the way that seems to really make sense for how I'm feeling it. So sometimes it takes like taking a little bit of a risk too on those patients.
Yeah, awesome. Well, thank you so much, Morgan. That is the end of our time today. I want to be respectful of everyone's time and make sure we can get folks to their next meetings or their patients. But yeah, really appreciate you presenting. We had a ton of great engagement in the Q&A. If you do have any feedback for the presenter or for us, please drop a comment in the link at the bottom of the page, and we will send the recording out to everybody afterwards. But thank you so much, Morgan.
Thank you. Thank you everyone for being on here today.